Good afternoon. If everyone will take their seats, we will finalize our last panel, which is New Insurance Models and the IPAB. Our moderator today is Ron Christie. Ron is an author, journalist, and television commentator. Previously, Ron served in the White House on both the vice president's and president's staffs, and after leaving the White House, Ron joined the law firm of Patton Boggs in Washington, where he was involved in health policy and healthcare reform. He now is the president of Christie Strategies, and I turn over to you, Ron.
Thank you. Good afternoon, everybody. All right, we are not going to start the last panel on what has been an enlightening group of sessions and roundtables, so I will try that again before we get started. Good afternoon. Thank you. Hello, Liz. It is a particular thrill for me to have had the opportunity not only to witness the proceedings here that the Aspen Health Stewardship Initiative has done, but also to sit with the august panel that we're about to have a very interesting, I hope, discussion on not only new insurance models, but the IPAB, which was created as part of the Patient Protection and Affordable Care Act. What we're going to do is that we would rather hear from you rather than talk amongst ourselves, which is a DC, unfortunately, practice where a lot of people get up and talk at you, but we want to have a engaging conversation with you. With that being said, however, I will use my moderator's prerogative just to sort of frame the debate, and then I will turn it over to Mark, and then, of course, we'll move to Tom and then to Jim Pinkerton for their comments. But it's very interesting for me as one who has been in the policy formulation process here in Washington for over 22 years to see in the healthcare reform bill, for perhaps the first time, Congress and the White House ceding power and ceding authority to a body that doesn't really directly report to the Congress or doesn't really directly report to the executive branch of government. And with that, what are the policy ramifications? What does it mean now to have a 15-member panel that is looking at slowing the rate of healthcare expenditures as it relates to the Medicare program? And particularly when there's no real form of recourse. Congress can either accept the recommendations, they can pass a new statute dealing with those recommendations, or if left to their own devices and they do nothing, which unfortunately we see a lot of in this town as of late, those specific recommendations by IPAB go into force. And what does that mean, and how will that help shape the delivery system that we have here in the United States and the years to come when we have full implementation? So with that, I'm going to turn it over to our panel. Two of the gentlemen you've had the opportunity to interact with and to speak with earlier today. Mark Gantz, a man who needs no introduction. We have Tom Miller here with us from the American Enterprise Institute, formerly from the Joint Economic Committee on Capitol Hill. The real smart guys, I can tell you, the ones who actually know what these numbers mean and how it will impact us all. And, of course, Jim Pinkerton, all-around rock star, who, of course, was the moderator from our last panel. So with that, with those dubious opening remarks, I turn it over to Mark Gantz. Mark?
Well, I think these panels work best when the initial remarks are short and just meant to sort of tee up conversation. I'm not going to focus on IPAB because that's not my area of expertise. I'm going to leave that to Tom and others. But I guess I'm going to start by talking a little bit about what's actually happening out across the country in terms of changes in the health insurance landscape, at least. I think that I said before the bill passed, when it was still being debated, that maybe one of the best outcomes of healthcare reform in whatever form it took would be that it would awaken an industry that had been relatively complacent and asleep for decades. And I think that, in fact, and I wasn't just talking about the health insurance industry, I was really talking about the healthcare industry and all the players within it. And I think that that's, in fact, happened in a relatively large way. The amount of change, the amount of innovation that I'm seeing, and I'm sitting around tables, industry tables, witnessing or being a part of, is more has happened in the last year than has happened in the entire time I've been in this business, and that is very, very exciting. I think there must be something that we talked about earlier about fear or feeling like your back is against the wall that causes that kind of activity. But I think that that's something that we can feel good about. What I really hope is that the ability to innovate is not inhibited by a tendency sometimes, particularly in the development of the exchanges, to overreach, to create too many rules, to tell sort of have a one-size-fits-all answer for how reimbursement should be structured, what an ACO looks like, what a medical home should be, and how insurers should be. But what I will say is I'll just mention a few things that are going on, and I'll talk about our company, and then that can maybe, I think that perhaps we're an illustration of what several companies are thinking about. First off, we really have shifted our focus over probably the last 5 years from being seeing ourselves as a health insurance company to seeing ourselves more around focused on health assurance. And that has taken us in some very new directions, a much more diverse set of businesses and business models that we use, as opposed to a single insurance model to determine how we go forward. And our belief is that that is really is advancing our ability to be a catalyst for transformation of healthcare. It's also caused us to innovate, do a lot of our innovation outside of the standard insurance business model. So taking competencies that we have learned and grown within the insurance company over a long period of time and recognizing how they can be leveraged in new and different ways into the marketplace in a much more direct-to-consumer or direct-to-provider fashion. We, over the last year, created an innovation R&D center, which we call our innovation force. And the focus is to incubate new ideas, either from inside the company or outside the company, in the area of reimbursement, in the area of wellness and health, in pharmacy benefit management, and many other areas to try to better make make for a more efficient system. And we've done a tremendous amount of work in the area of understanding how consumers want to interface with their healthcare providers. Our focus has really been less about trying to change consumer behavior, change provider behavior in a direct fashion, but more to create a better frame around the physician-patient relationship or the patient-provider relationship in a broader sense. So that it works better, it's more efficient, it's more transparent in the area of price and quality, and to harness the power of social networking to, in a sense, automate and digitize the backyard fence discussions or the discussions over coffee that people have about their diseases, about their interactions with their healthcare providers. We learned, for example, that what patients really wanted most of all to start with in terms of that kind of networking was they wanted more information about what other people thought of their physician or their hospital, and they wanted to share that with other people as well. So instead of going down the road of trying to provide a whole lot of quality information as defined by perhaps different industry sectors, we said, let's start. It was our customers and a broader set of consumers in our part of the world said, don't invest there. I'm not that interested. I want to know about what's the experience and when I go and see my doctor, and do the doctors or the hospitals, are they clean? Is the wait a long time? Are there those sort of more gritty measures of quality is what people really what draws them into the conversation, and then you can take it from there and take it to a broader conversation around quality. In the area of reimbursement transformation, we've spent a great deal of time working with the Boeing company and partnered with them on a 2.5-year pilot where some of the sickest Boeing employees with multiple medical conditions such as hypertension, diabetes, heart problems, and the like volunteered through an incentive, volunteered for a program centered on a medical home concept. They were matched with teams of doctors and nurses who communicated, motivated, coached, and counseled them on all aspects of their conditions via in-person visits, phone calls, and emails. A key component of this study was to test an unusual payment combination that involved both service and monthly fees, something that we had not done before and insurers generally have not done in the past. After about a 1.5 to 2 year period where we weren't sure what the results were going to be, and it just takes a little time. You have to build a culture around to support this. The longer-term study proved very, very positive in terms of the sense of quality of the outcome and the management of the patients, as well as the cost that was being incurred in taking care of them. And Mercer Consulting, who was also studying this and a partner with us, reported that patient satisfaction and doctor and nurse satisfaction, along with clinical indicators and costs, all improved significantly. So that is an example of a new and a different way of thinking about reimbursement and really reimbursing for a different kind of behaviors that is working. And we are now expanding. We just announced that we are going forward in a big way with Everett Clinic and the Virginia Mason Clinic up in the Seattle area, two very fine institutions. And we are also implementing this in the state of Oregon under the auspices of the Oregon Healthcare Leadership Council. Another thing that we're focusing on is value-based health insurance, and we are working with a particular company to create a stronger partnership in terms of how employees in that company interface with their healthcare benefits. And this company, who will remain nameless at this point, estimates that they'll realize savings of at least 10% by offering this new plan, simply by better managing chronic disease and focusing on wellness amongst its employee pool. This company has quite a few diabetics, and the way we've structured it is that they will pay very little to stay on track in managing their diabetes. On the other hand, employees will pay much higher deductibles, coinsurance, and copayments for services that offer very little clinical value, such as spinal surgery for pain, shoulder surgery for osteoarthritis, knee arthroscopy, coronary artery bypass grafting, upper endoscopies, visits to the emergency room, and imaging tests. So it's not a machete view, but it's more of a scalpel view of what works and what doesn't, and really trying to incentivize people to pursue lifestyle and therapies that can offer a greater degree of value for less dollars. So those are just two examples in the area of reimbursement and incentives directly to individuals that seem to be showing some promise. And my hope is that we will allow for more of that to occur, and that perhaps CMS and others will learn from those experiments and apply them in the Medicare program, as opposed, and so that it's a dynamic process of learning within the ecosystem. I'll stop there.
Thank you, Ron and Mark and Jim to come. When I heard you were going to be talking about new insurance models, I was surprised that they're actually talking about ones in the real world. I come from the policy world of the Patient Protection and Affordable Care Act, where we have a series of science fair projects or walking unicorns, which are about to arrive overnight, apparently. Now at AEI, we'll have a project unveiled next week called Beyond, or next month early, called Beyond Repeal and Replace, some new ideas for health reform. But that's not what I'm here for today. I'm supposed to talk about iPad. Get into cross-promotional plugs while I can. 4 little letters. What could it possibly be? Well, what I'm going to talk about is, all right, what is iPad basically, where it came from, how it operates in kind of a basic neutral sense, then a little translation into what are some of the decoded details of the iPad. Why did this get injected into the legislation? What purpose is it supposed to serve? Some criticism about it and what might be ahead in terms of the the life expectancy of this particular policy mechanism. Well, IPAB is supposed to be an appointed body, 15 members by the president with the usual allocations among nodding from the Congress and the House and Senate sides. It's supposed to enforce by basically formulas, some limits on the growth of per capita Medicare spending. And those recommendations, of course, miraculously are not supposed to in any way prevent you maintaining or enhancing beneficiary health care access and quality of care at the same time, but we'll see about that. Where did it come from? It started getting talked about, I guess, in the summer of 2009. Jay Rockefeller in the Senate had one version of it, kind of MedPAC, which gives recommendations on Medicare policy to Congress, but MedPAC on steroids. Then it got embraced a little bit by the White House, particularly when he was OMB director. Peter Orszag is a way to say, see, we are bending that cost curve. It's like Gumby, it can move. It went through several iterations. When it was in the Senate, legislation was called originally the Independent Medicare Advisory Board. Then it went into Witness Protection in the Reconciliation Act and came out with the name IPAB, which is pretty close in a software sense to basically a rationing application for your healthcare operating system, if you know your Apple software. But I don't know whether it's your iMac on your iPad or your iPad on your iMab, but you get the general idea. So how does it operate? Well, it starts in motion. I'll get to the formulas in a second, hopefully. Raise your hands if you know everything. I don't have to repeat any of this stuff. The chief actuary at CMS is supposed to make projections, starting actually in 2013, as to what the per capita growth rate is for Medicare spending, and they do it 2 years out, and they do these averages of 5 years. Well, that's mirage. But in any case, if what they're projecting exceeds what is supposed to be set as these various baseline standards, then the IPAB members are supposed to propose ways to reduce it, to bring it back to that baseline, more or less, with some variations in a year after first having done the indexed year for all that type of stuff. They submit initially their advice and reports to Congress. The first one will probably start getting prepared, if this all goes by clockwork, in January of 2014, and then the real effects would kick in 2015, depending on what the numbers show. And this is all to demonstrate how we can improve the payment system to not have per capita spending rise as much as it might otherwise be going. The reductions are supposed to roughly speaking, be about at least equal to what is set as the savings target for the year, but there's some exceptions to that as well. There's no proposal, of course, if it turns out that Medicare per capita spending isn't growing as fast as probably they think it is and is going to happen in the future. So the IPAB could, in essence, not have to issue a report if miracle of miracles trends change. Now, if the board, though, fails to submit a report and is supposed to do its job, then the Secretary of HHS has to step in a little bit later on in that January if they don't find a way to reach a consensus on what they're going to recommend. There are all kinds, as Ron was alluding to, accelerated congressional proceedings saying that they have to delay later after they hurry up and first have to pay attention to it. But there's timelines where the normal ways in which things get sidetracked don't happen. And if the Congress doesn't move, the committees don't move by like April of that year, then they'll have automatically discharged to be processed potentially on the floor. But the rules are a little rigged in the sense that once the targets have been set and the savings requirements are set in the various proposals, if the Congress doesn't come up with something else which meets that savings goal, then the stuff goes into effect. And the rules are even stacked so that the only way to override this requirement in future legislation is not only that the House and Senate have to pass a new law, but in case of the Senate, they actually have to have a 3/5 vote to change this requirement. So it's trying to stack procedurally the idea that this will be delivered from on high. The way in which this is calculated, in essence, is in the early years, getting to almost 2017, the averaging of the growth is done as a combination of the consumer price index and the medical price index. It's kind of blended together, so that's a way to have the average rate of growth till 2018. After that, then that target rate of growth is the growth of nominal GDP plus 1%. These are arbitrary figures, but if you can't be arbitrary, there's no fun in doing the whole thing anyway. in the early years, the targets don't have to be hit exactly. There's like a margin for error. It's the lesser of, and you know it'll be the lesser of, as opposed to the spread between what the per capita spending is projected as the average over 5 years versus these targets I just gave you. It's either that amount, which could be larger, or it starts at like 0.5% in 2015, not that hard. Then it goes up eventually to 1.5% in 2018 and years beyond. So that's actually the minimum standard as opposed to what might be a even wider spread. There's some exceptions to this, particularly the hospitals who cut their own deals and say they gave it the office in return for future customers in the future. They're pretty much outside of this process until, depending on how you want to calculate, I guess about 2019, because they've already done their make-believe productivity adjustments as part of a political deal. But then they come into play a little bit later on. It's a little unclear as to how the doctors get hit because it depends what happens with the sustainable growth rate. But in all likelihood, that's not sustainable either. In doing the cuts, this is supposed to only apply to Medicare. And they can go independent and pull stuff out of Part C and Part D, even though the spending is actually calculated on Part A, B, and D. But in addition to that, the IPAB has some other opportunities, not the same enforcement device, where they will at least every other year make recommendations to Congress about overall national health expenditure targets and growth and what they think might be a good idea in that regard. That'll start in January of 2015. It's not quite the same automatic enforcement device in that regard. There are things that aren't on the table, though, that they can't do, which tells you a lot about the process. In making these recommendations, how do we meet, get the savings to fit this target rate? You can't make any recommendations to ration health care, at least officially, raise revenue, increase premiums in Medicare, increase cost sharing by beneficiaries, restrict benefits, or modify eligibility criteria. As you go down that checklist, you begin to say, well, what's left? Aha! I think across-the-board reimbursement cuts might just do the trick, because that's pretty much all that's left to be done. There's some speculation whether you might get some more exotic payment rules where you pay for some things and not others in a different manner if that comes about. Potentially you could change where you won't reimburse certain products or services. I think that's within the zone of what creative price controllers could come up with, but it's not officially right there. Whether we get to the selective contracting in a Medicare fee-for-service mode is a little hard to figure out. Let's convert, though, to what's really going on here. This is the old progressive politics view of the rule of experts. If we can get the smartest guys in the room to figure out what to do and just keep it away from everybody else in politics, we can get the results. That's at least one idea that motivated this, and it's also basically an enforcement mechanism where the IPAB comes around and breaks the kneecaps of anybody who hasn't already gotten in line with all the other stuff that's been tried that turned out not to meet the goal, in order to have some type of upper payment cap on Medicare spending initially and perhaps other things later on. There's another way to describe this, though. If you know your Greek tragedy literature and can do the Latin translations, the technical term for this is deus ex machina, which is a special device, the god that comes from the machine. When you can't figure out any other way to find a solution, you just assume it's going to kind of spring up out of a floorboard or a trap door, and that's pretty much how the IPAB works in this way. More recent modern critics of this type of approach say it shows lack of imagination and creativity by those who are writing the story, but sometimes when you're stuck in a corner and don't have any other way out of it, voila, you come up with your particular device. So what are some areas of criticism for the IPAB? It has a bit of a short-term bias because you're talking about, do we hit the number next year? We're not talking about, fundamental long-term reforms that might pay off in 5 or 10 years. You get driven by a formula to hit a particular set of numbers if you want to proceed in that way. And there's also the problem that what happens if you've got a detachment between Medicare spending rates and overall health care spending rates. Well, it's all geared to per capita Medicare spending, regardless of what else is going on in the universe. And there's a broader disconnect between going after Medicare spending in isolation apart from private health care spending, pro and con on either front. Also, the criticisms are you're basically, which is the design of this, to replace elected officials with relatively unaccountable appointed ones, which still operate under political constraints and all the various ways in which people try to maneuver and influence them, but they're less directly tied to the consequences of the decisions they make. And of course, from the view on Capitol Hill, this is Harumph once again usurped our authority. We don't want to do anything about Medicare spending, but we'll be real sure that no one else does either, so that we can pretend that we're still in control. So what's going to happen on this front? Despite speculation, IPAB's not going to be killed outright. It's not going to be a mercy killing like a baby seal in the first couple of years, but it's more likely to be slowed down. It's going to be hard to find people to serve on this board. They're not paid a lot. They're going to take a lot of heat, although they can imagine they're masters of the universe. So it may be hard to actually first get people to fill out the IPAB and then also get them through a less than friendly Senate in all likelihood. There may be some efforts to slow it down by not feeding it with the funding that it would otherwise expect. So the likelihood is that this may die a slow, quiet death over several years as opposed to the great horrors that people are imagining. I'll stop at this point.
Thanks. I want you to know that I had some jokes too, but after Tom, I figure I'm just not going to even try. So my presentation will be completely devoid of humor.
I like the bill.
You know, just listening to Mark and Tom, you know, we see a discussion of the current private insurance market, and or part of it at least, and the discussion of where IPAB is headed. And it occurs to me, you can just say, look, that's sort of the left and the right, or you know, not to associate Tom with the left, but to say that that's a discussion of the two big ideas that are sort of floating around there in the Democratic Party and the Republican Party. You know, I think that it's, you know, I agree with Tom's critique of IPAB. I will just say that it will change its name. I'm sure of that. You know, we had MedFed and then MedPAC and then MedCAC and then every one of those things becomes unpopular. People get a bead on it and they decide they don't like it, so they change the name. But you know, one thing you learn in this town: no idea whether you like it or not goes away completely. Something like this will be around for a long time to come. Some presidential candidate will be saying in 2020, you know, I've got a wonderful new idea. It'll be price controls on medicine, and people say that's great, and there'll be cyclicalness to this. But I think at the same time, that's the left, and again, I think they'll be on this for forever. On the right, or whatever the right is called in some future date, I think you've seen a kind of an evolution, though, on thinking on the way the insurance market works, and I think it's kind of consequential for where we're headed on this. I think 50 or 60 years ago, you know, health wasn't much of an issue. It was 5% of GDP. You know, it wasn't very controversial. But if you'd asked the average National Review reading conservative of 1960, you know, what do you think about plans for socialized medicine like they have in England? He or she would have said, you know, as our hero William Buckley said, our purpose here is to stand athwart the railroad tracks of history, yelling stop. So whatever it is the left has in mind, we're against. As Russell Kirk said, we're attached to the permanent things, and banks and insurance companies, which have headquarters that look like Greek temples and so on, seem permanent enough to us, and so let's just keep them the way they are. And that was I think the view of the right overall into the 60s. And then so that was phase one, what we'll just call sort of traditional paleocon conservatives. Then the second generation was what I'll call, for the lack of a better word, modernizing conservatives. Irving Kristol in his, you know, public interest magazine days, Jack Kemp. These are people who said, we're going to take the goals of the left but do it in a better way. This is sort of the empowerment, enterprise zones. So again, we agree. Every kid ought to get educated. Everybody ought to get health care. But you guys with your bureaucrats don't know how to do it. We'll do it with market forces and so on. And on health care, Stuart Butler. You know, look, everybody's going to get insured, but we're going to do it with market forces. And this group spoke in a language of social science, of modernization. In many ways, they shared a lot of the linguistics as well as the goals of the left. And the ultimate example of this, in terms of on the right, was Romney Care in Massachusetts. Which every left-wing blogger delights in saying is the father of Obamacare, much to the Romney campaign's consternation. But I
call
think
that demon seed.
and you know, just President Obama in his appearance on 60 Minutes just a week or two ago said, we thought we could really work with Republicans on the health care bill because we based our thing on Romneycare. And I think they were genuinely surprised at how quickly the right opinion on health care had changed from what I call these modernizing conservatives to what I'll call the new libertarians. Right here, here's one. I think. Well, maybe it's a new paleo libertarian. That makes total sense to me. And I think it's important to understand that just this new critique, which is totally where the Tea Partiers are coming from, is profoundly different than where the modernizing conservatives were. I mean, Stuart Butler doesn't have his job anymore at Heritage, I think in part because of the influence on this. And that is, look, that the current system is just not to be trusted. Tom's play on the smartest guys in the room, I'm sure a lot of you recognize, that's a play on the title of that book about Enron. He knew what he was saying when he said that. I know Tom. And I think that this spirit, though, poses a major, major challenge to the insurance industry. When Paul Ryan, for example, says that the state of the insurance market now and the poor information across the system is comparable to the stock market before the 1929 crash. That's in his roadmap. That's kind of a stinging indictment. And again, in an 82-page document, you can put a lot of stuff that nobody really quite grasps, but whoever wrote it certainly knew what he or she had in mind in writing it, and it's a pretty fierce critique of the status quo. And if I understand this properly, the Ryan plan, doing away with the deduction for employers, that kind of, I'll let Tom quantify it, that puts a pretty big hole in employers' desire to have provide insurance to their employees under the current system. Now, what makes it even more interesting is that the Bowles-Simpson plan takes the same idea. So we could be looking at a major, major change in the way that health insurance is delivered in this country. And of course, the new libertarians, have a counter model, which is health savings accounts and the medical savings accounts and so on. And this is very much a fight. You couldn't even begin to get more than 20 or 30 Republicans on Capitol Hill to agree on any one version of these plans. It's still very much in ferment. And they still have to wrestle with, Kenneth Arrow won a Nobel Prize for saying that, look, medicine really isn't like a market thing. You don't want to consume it, asymmetric information and so on. So there's some major, major challenges, which Tom, I know for sure, is more than willing to take on as he strives for his own Nobel Prize, at least the one given.
Penn was missing some information at the time.
I would just add, though, that there are, in this whole discussion of insurance, whether it's and cost controls, whether it's IPAB or health savings accounts, there are some grinding realities that I don't think have quite been factored in. If we all get diabetes as we get older, that's expensive, no matter who pays for it. If we all get Alzheimer's when we get older, that's expensive too, no matter who pays for it. So there's a lack of thinking about the true curve, which is the disease itself, and whether or not you get it. That the current policy discussion, left and right, I don't think really fully understands or it was willing to embrace, because it, frankly, it disempowers economists and wonks and gives power over to scientists and people in faraway places who, where it's much more fun to have the discussion here. But I think that down the road somewhere we're going to see a kind of a power struggle, because I think that, look, in the fondest dreams of the left of single payer run by NHS and NICE, and the fondest dreams of the libertarian right, where it's all the free market, I don't think we'll get to either one of those ever. I think there's always going to be kind of a pluralist system and a mix. And we're going to see various people, as we were discussing in the previous panel about all the different players who have bits and pieces of information, whether it's the IT or the doctors or the research facilities or the pharma companies or whoever. You're going to have to, the great challenge is going to be, okay, who's going to provide I won't say the word paradigm, but I'll say the word the Kybernon. Who's going to provide the structure by which all this information winds up so that this thing, in addition to being a nice phone and personal data assistant, also becomes the equivalent of a tricorder, like we saw in Star Trek, where they just point it at you, and whether the doctor knows what he's doing or not, or whether he's hungover or not.
Damn it, Jim, I'm not a doctor.
But you still get a good diagnosis because the tricorder has figured it out. Now, I realize we're I think under the current track, we'll never get there. Literally, I don't mean long ways. I mean literally never, because of the things I said about the trial lawyers before. With technology, we could get there, but you'd have to find somebody you trust, or something that you trust, to coordinate it. And I think the government will make a play at it. I think the insurance industry will make a play at it. I think Google and Microsoft will make a play at it. Facebook will make an effort. I mean, who knows who will do it? And now we've got a very, very complicated situation. And I'll just say flat out right now, I have no idea who will do that, if anybody. And in keeping with the temperature and the atmosphere out there, I'll end on that cheery note.
Thank you, Jim. Thank you, gentlemen, very much. And Jim didn't think he was funny. I mean, the tricorder reference, really? That was pretty good. What I will do now is I'll ask each one of the panelists a question based on your remarks to elicit commentary, and then use my moderator's prerogative to, of course, ask one last question, and then throw it out to you so we can engage in dialogue. And Mark, the first question goes to you, and I thought it was very interesting that you noted that you were moving away from a health insurance model to a health assurance model for your delivery of care. And I'm just wondering, from your thoughts and your perspectives as we talk about new insurance models, do you think that the Patient Protection and Affordable Care Act is going to do more to stifle or to invigorate innovation?
See, I think I'm of two minds around this, because one of the things that I've expressed this morning, a concern I have about the structure of the bill is that it's going to encourage a lot of people to choose to go outside the system and stay outside the system until they need care, because the mandate is not very great. And if you compare the mandate at its heaviest, which is $700 a year, against the cost of a health insurance product, which will be $7,000 roughly. There's a lot of people who will make the economic choice that they're pretty healthy people, and they can find something better to do with that $7,000. And so I think as in 2014, we'll see a number of people who have been sitting outside the system come in. I think we'll see an equal number or greater number eventually move out. We saw this in Washington in 1993 with the passage of a similar healthcare reform bill up there. And so when that happens, it's going to be a very interesting bit of innovation, because I think that the millions of people who are sitting outside the health insurance system are still going to want predictable access to care. Mm-hmm. They're just going to do it in a more of a market-based way. And so I think you could see a tremendous amount of innovation. There already, in Portland, there's already some movement in that direction with the advent of a company called Zoom Care and the clinics that it's providing in a more retail context. And the early returns on that is that patients are extremely satisfied, excited about the care that they get there. The model of being able to do it, arrange their appointments online, go there, prices are posted, it's predictable, it stands in stark contrast to the rather opaque mainstream healthcare system. And people are enjoying that. So I think that there could be a great deal of innovation in the way that care is delivered in that environment, which could fundamentally alter the culture of healthcare and the healthcare delivery systems as people adjust to that kind of, literally having many, many patients coming to them who are going to be paying direct, and therefore having different expectations than a patient who's coming in and only has a copay or a coinsurance. On the other hand, so that could be a real positive. I also think, as I said, that that the very fact that the bill passed itself has created a new level of engagement between insurers and providers in trying to figure out how we can, restructure the economic relationship. And when providers come to us and say, hey, we'd like to partner with you. Having been down that road before where partnership meant they wanted more revenue or more volume, our approach has been, look, we'd love to partner with you with a couple principles in mind. Number one, this has to be focused on how do we serve patients better. So number one, will the patient experience in your facility markedly improve as a result of this collaboration? Second principle, you will receive less revenue from us than you do now. And that usually stops them a little bit. What do you mean? Well, if we want to reduce costs to the system, the only way we're going to reduce costs is if we're paying you less. You're consuming less healthcare. And then third, we want to change the way we reimburse to help reinforce cultural and enhance and reinforce cultural change that will allow your margin to be the same as you have today, just be able to achieve that with less revenue. And it's been really fun engaging with healthcare delivery systems on the basis of those principles. And I think we're making some real progress. So I think that's a positive. If I have a concern, it's about some of the conversations, some of the folks who are close to the development of exchanges, who have in their mind already, they've already figured out what the model is, and they think they know what it is, and they want to get at and change the delivery model through the exchange. So they want the exchange to be something really, really big, kind of boil the ocean. And if that kind of thinking infects this process, then I think you will stifle innovation because it will be everyone has to do it that way. And I think that would be a mistake. So that's the one note of caution I have is that I think that we have to make sure that we allow for a little bit of the chaos of innovation, which often leads to very good result, and not be too quick to jump to a conclusion and say it must be that way, that model.
Thank you, Mark. And I think that's a perfect segue to the question that I was going to ask Tom. Tom, one of the things that you had said, a potential criticism of IPAB was that, is this really going to bring what is perceived to be the smartest guys in the room where they, we know best, we're the 15 smartest and brightest. And yet I remember and I reflect on the comments that former OMB Director Peter Orszag had said that when we look at all the aspects of the healthcare reform bill decades from now, that one of the things that he believes will be the most far-reaching and one of the most important aspects is IPAB. And based on your thoughts of the smartest guys in the room, could there be something to that? Could there be something that perhaps in the initial rollout that we don't like it, but do you think that decades from now that people will look back and say, this is actually a pretty good thing?
No.
Hey, I had to try my nonpartisan, not ideological
IPAB is
question.
actually pretty dumb. It's just a made-up backstop when everything else that all these other bright ideas failed, and they say we'll go back to revert to formula and just take a little haircut off the top, and you hardly miss it at all. I referred to the Deus Ex Machina. The actual description of it is a device of the god that is entirely artificial or conceived by man, looking a lot like Peter Orszag. Look, there's a lot of important things that need to go on. I think Mark outlined a number of them, and I'm been aware of his work on the information front and insurance for a number of years. They've been one of the leaders in that area. Clearly, we have to have a different type of system which delivers health care that's cheaper, better, and faster, not in the same ways. But to think that you can run it through this legislative grid and say, aha, I have invented a way you're going to do this, as opposed to perhaps create a set of incentives where everybody is motivated to find something that does work better. You're looking for the outcome. You're not pre-designing what the manufacturing base is in the formula in order to get there. That's a start in that direction. But this whole construct is partly to disengage the patient and the consumer. Do you have to care about what it costs? No, we got you covered on that one. Too much cost sharing, too much premium. Oh, no, you're protected relative to income in that front. So you've actually deadened the nerve endings from the people who should be looking for something better and challenging that in return. In terms of encouraging innovation, this is a design which says everything that's not mandatory will be prohibited eventually. the greatest amount of innovation is figuring out, with the rats in the maze, whether they can find the hidden cheese or find a way to gnaw their way out. That's considered innovation in Washington, the policy front, when you box people in from doing what is in their own self-interest in that regard. The mandates, everybody who's selling a product would like to force their customers to buy it. That's not going to work in our political system. It's breaking down already. That's going to continue that way. The alternative is to provide a product that people want to buy. That means it costs less and does more, as opposed to, you have to buy it under law, which is not going to happen in that regard. Now, Jim was talking about, the Ryan Roadmap, which is a nice blueprint from the folks about to design the interstate highway system. It needs some rest stops, it needs some speed limits, and some directional signs, a little navigational assistance. That's what we're working on, and we'll have something on that, Jim Capret and I, in a couple of weeks. But it's a start in direction of saying the resources are not, they're not unlimited. We need to allocate them better. But to some extent, you're going to have to actually get value for what you're spending, regardless of whose pocket you think it came out of. And that's the other area that we don't talk about on this front is all this driving toward, if we can organize this way and organize that way, we'll have this great integrated system. We're about to, possibly go into a form of a bulking up on steroids, consolidation of the last remaining survivors in the healthcare system are all working for each other. The hospitals have bought up all the physician practices, and then the insurers are fighting with them, and the government's fighting with them, and it's like a bunch of sumo wrestlers trying to get, a death grip on each other when it's too big and they choke and they can't actually be nimble in order to move around. But aside from that, I'm pretty encouraged by what's happening.
Excellent. There's real no ambiguity as to where you're coming from. Thank you, Tom. And Jim, you mentioned, I'm not sure where I fall into this either, the paleocon, the neocon, the neo-libertarian. But one thing that comes to mind, you would think with the explosion of government spending in Washington that conservatives would like the idea of placing a cap on the rate of growth for Medicare expenses. So my question to you is, do you think that this cap is fiscally responsible, or do you think this is merely government price controls in disguise?
Yeah, I would take the word conservative. Conservatives would like a cap. You would think they would like a cap. And I distinguish between the business community, the Chamber of Commerce, which 100% wants the cap. I think the secret of the Obamacare was that a good chunk of the business community was for it, even though they didn't say so. And plenty of them said so. So no, they would love to have it, to say, I'm sorry, we can't spend more than X on you, no matter what happens to you. I think libertarians are sort of torn between, on the one hand, they think people should be free, and on the other hand, they don't think the government should spend very much, and so they haven't.
You can spend your own money.
You can spend your own money. There you are. You can spend your own money. You can sleep under the bridge. You can spend your own money. I think that. And the Republican Party, which doesn't quite fit into either of those categories of pure libertarian or the Chamber of Commerce, simultaneously campaigned on protecting Medicare and sort of, I guess, notionally restoring, the cuts in Medicare Advantage, with balancing the budget, which left you with Jim DeMint saying on Meet the Press, I think a week ago Sunday, well, of course, we're not going to cut Social Security. We're not going to cut Medicare. There won't be any cuts in that at all. We're going to do earmark reform, which I think will be kind of a problem for him when the Bowles-Simpson Commission, which sort of, I think, met a thundering renunciation by the political class on the first couple of days when it came out, but then the pundit class kind of picked it up and carried it over the weekend, and now I think it's a permanent feature of sort of static analysis in our laps, where every sort of non-elected pundit can say, well, what are you going to do? What are you going to cut? What are you going to cut? What are you going to cut? And I think the limitations of the Bowles-Simpson Commission, like the fact that they don't talk about new ideas on energy development or new ideas on curing diseases as opposed to treating diseases, none of that stuff is in there. I'm afraid that the pundit class will then fall into either you're a spending cutter or a tax increaser, which is a horrible choice for politicians to have to make in that static analysis trap. And so I predict that the politicians will punt until we become Greece.
Politicians punting? There's a shock. Okay, I'm going to exercise my own prerogative not to ask my question that I was going to ask. And now now the floor is open to you. Questions?
I have two questions on the Affordable Care Act's targets to reduce or get cost savings in Medicare. One is, as far as the demonstration projects for accountable care organizations that are Medicare specific, do you think enough has been allocated there? Do you think that, those are very innovative models. They're not new insurance models, but do you think enough is being invested there? And the second is the targeting of Medicare Advantage plans. There seems to be some fat on the bone there. There's some pretty good measurement systems out there. The STAR rating system that looks at clinical outcomes and patient experience and administrative. Like to hear about that as well. Thank you.
All right. ACOs. Theoretically, there might be a few that exist. The design, despite statements to the contrary, is very hospital-centric. So we're rebuilding the hospital universe and calling it an ACO. And it's not a matter of investing money in it. If there was a reward for doing the job better, you can set up a basic incentive structure, then go ahead and find out whether someone can actually meet the model. But there's been a lot of puffery and not much demonstration on the ground thus far, although everybody will tell you that their organization is now an ACO. No one else realizes it, but they figured out that the model fits them. What we need are APOs, accountable political organizations. We don't have very many of those. Medicare Advantage. I am not I know the playbook to talk about kind of how the special populations are served and what a wonderful thing Medicare Advantage was. You got one contorted solution to deal with another contorted mistake. There's a different approach to having private plans in Medicare. It's called a level playing field, but you don't use the fee-for-service payments as the model for that. We go back to different versions of the 99 Bipartisan Commission, a better version of competitive bidding, competitive pricing, where you say, look, here's what the package is. What does it cost? In some places, you're not going to have any private plans because they don't make any sense. In other places, they're going to eat the clock of wipe out a good bit of fee-for-service, and then office holders get scared of that as well because it looks like the premiums go up. Just let the better system work where it works, but don't create a competition where you give private plans more money in order to deliver more benefits, but nobody's actually doing a more efficient job. So both sides have kind of gone to the extreme in that. But the immediate playbook is to take it out of the hide of the private plans. We'll have about half as many of them as we did before. That's not a solution either, and we've done all kinds of distorted things in Medicare private plan payment. But no one wants competition because that would be un-American.
Jim, Mark, either of you guys?
Yeah, I would just say that, let's not forget there's a lawsuit going on. It really doesn't exactly address what you're talking about. But I think the political energy in this town, has Donald Berwick been confirmed anything? Is he a legal officer? He's acting. When does his...
Taking questions tomorrow.
Right, and when does his term come out? When do you...
Next year.
Okay, right. So we've
year.
got a real crisis of legitimacy in terms of the minds of a lot of people on these things. I would be very surprised to see much happen. I wouldn't want to be the bureaucrat then who gets hauled to testify before Congress on what I just did if it was controversial.
I think that the biggest concern I have around Medicare Advantage, because I come from a part of the country where we're pretty efficient relative to others, the disparity of payments that exist around the country related to this is a major issue that I would love to see addressed. Because if you're talking about fat, you have systems that, in a sense, reward inefficiency by by providers, and by providing more money to those plans that operate in those very, very expensive environments. And it'd be nice to see that get addressed. Politically, it's very difficult because that it just so happens that some of those real fat areas are political power bases for, and so it makes it difficult. But that is the issue that needs to get addressed first, in my view.
Question from this side of the room. Going once. Sold.
At the end of the day.
Further questions? Yes.
Implementing new payment models, as you all know, is extremely expensive. And I guess the question is, how much of a disincentive are the MLR rules in the Affordable Care Act as a result? How much of a disincentive is that for implementing new payment models, more on the commercial side?
That's a really good question. I think it's too early to tell. I I think the whole approach to creating the MLR restrictions was probably misguided because I think it's going to lead to a number of unintended consequences. But it's in the bill, and so the regulations will come out, and we'll figure out how to comply. And I think it will be. I would say that most people in my industry know that we need to change the fundamental economic model by which the system operates today. And so I think there's going to still be a tremendous amount of energy put toward that because there's a greater good to be accomplished. And MLRs will be a barrier probably to progress, but they will not stop progress because I think there's a belief we have got to get at this issue of how much money is being spent in the system, and we've got to change the reimbursement methodology because the current methodology leads to waste.
In the case of MLR, we'll have fewer insurers and fewer plans, particularly in the portions of the market that have been targeted where they'll bite to some degree. You do get some perverse incentives where sometimes investing some money doesn't pay off, and there's going to be a counter incentive to actually increase the denominator and have higher premiums in order to match what otherwise the numbers would be, and you've got all kinds of contortions going on that. You will see a rather detailed critique of that in about 2 weeks coming out of AEI from one of our papers. But in the larger sense, we are so. This is getting back to what Jim was saying before. We are so insurance-centric. And so where's the money going? Who's got it? Where's it coming back and forth on the payment side? That we do lose sight of the idea that maybe, just possibly, this entire system should be about improving your health rather than passing money back and forth and wondering whether it made a difference. And that reaches way beyond the insurance mechanism. In some cases, it reaches way beyond the conventional health services mechanism. I mean, I've done work in this regard beyond health insurance. There's a lot more going on that produces your health. Unfortunately, we've got a slight problem with the installed base. Most of the folks have already messed up their bodies, and they're not coming back. You can do great wonders with embryos at the moment, but it's a long turnaround time to completely complete that. But we're going to have to invest in other ways to live leaner and get other ways to improve our health, because it sure isn't going to come out of this system as it currently is configured.
Other questions? Well, I will ask my question. Looking at the previous panel, we had a very good discussion, I thought, on comparative effectiveness. And one of the things that has disappointed many who were looking for genuine healthcare reform was the fact that 1 out of 2 Americans will develop a chronic disease in their lifetime. And you look at the number of expenditures going out of the door for Medicare of often 75%. My question to you, as it relates to each one of you on the panel, is do you think that CER will do more to deny services or deny care because it's deemed as being not cost efficient, or do you think this is a efficient method and an efficient model to move forward to contain costs?
I'll start there because we've been doing comparative effectiveness in our pharmacy area for several years, and but the model we've chosen is not to use it to deny. We've used it to inform both patients and physicians about the effectiveness, the comparative effectiveness of various drugs, particularly new drugs, therapies that come on the market. And what we found is by tying that to incentives, it actually leads to a better outcome. And so I think comparative effectiveness is a good idea. It's all in the execution. And again, is the focus on getting more information in a user-friendly format to those who are consuming, or is it about people in rooms swirling their glasses of Chardonnay, talking in high-minded ways about what's quality, where it doesn't actually, and then it's sort of this smartest people in the room kind of concept, and we'll decide for you what you get. I hope it's not the latter. I hope what it is that it will be focused on getting information in the hands of patients and consumers and in their primary care physicians, so that there's greater knowledge about when that script is written, that it's for the most effective treatment available.
Mark has the positive vision of comparative effectiveness, and it certainly could turn out to be that way. But in the Joe and Lie sense of how's the French Revolution going to turn out, too soon to tell. It depends upon who's setting the weights and measures and what agenda is driving it. Because in a resource-constrained environment, the temptation is great to take shortcuts and not just inform, but put your thumb on the scale and decide that this is how it's going to turn out in that regard. I just put a little bit of a caution. I know folks like to throw around statistics like this which feed their revenue base, but the problem with saying that everybody is suffering from a chronic disease is that's life. It happened all the time. If you go back in history, you should look at some Civil War veterans and what they were carrying in their bodies in terms of chronic disease. It's a labeling mechanism to, once again, prove that when people get sick, it costs a lot of money to have problems. We need to deal with it, but it's not like we've suddenly become this accumulation of massive, maladies and woes that has never been happened in mankind before. We can treat it. And that then creates opportunities to sometimes treat it well, sometimes over-treat it, and that's where the ticker starts running. So we got to find an effective way to deal with it. It's not just suddenly something that if we could just target it, we'll make it go away instantly.
Yeah, I would just add a quote, I think that applies, from the late Jack Kemp, who said, look, people don't care that you know until they know that you care. And if they don't trust you, if they mistrust your motives, then they're not going to believe anything you say, no matter how many books and documents and computer tapes you wave in front of them. And I think that from a political point of view, we've sort of reached a point, and who knows how long it'll last, where people really don't trust anybody in power. The Tea Party movement is about 18%, self-described Tea Partiers in this country, about 18% of the country. So that's 82% aren't Tea Partiers by their own definition. That's most. But Scott Rasmussen, who's a pollster, has data that says that just to illustrate the split between the elites and the masses. And for example, he has 86% of the elites in this country think that the country's headed in the right direction. 86%. If you're doing well, if your house is underwater, but that's okay if you got 5 more, then you're not too. Then that's one thing. But 86% of elites think we're going in the right direction. 19% of ordinary people feel that way. 77% of the elite think the political system is not broken. Repeat, not broken, and 74% of the masses think it is broken. So in that kind of environment, you can. Again, I just don't think people are going to listen to much of anything that the elites say. Now, we do live in a world of limits, and there's, you got to die of something, and there's only so much money. But I think this will just be a prolonged and difficult fight, which I think the result will be that they change the name of CER to something else.
Yep. Is there one last question from the room? Going once. Yes. Young lady in the back.
Hi, going back to Berwick's acting status. I'm just interested in hearing from the panel on whether the Center for Medicaid Medicare Innovation, CMMI, will be rolled out, and if so, if it will be effective in achieving payment reform on a broad scale.
You're looking for mandatory innovation through government, which is an interesting approach. Now, we do have the alternative model, I suppose, in the old days of DARPA and skunkworks with federal funding, but I don't think that's the model they're going to be using at CMS. I'm sure it'll be rolled out. I'm sure it'll be rolled over, go pause up, and spend some money. And out of whatever's done, there are a few things that they could probably claim were their innovations that were happening elsewhere. So that's business as usual.
Yeah, I guess I'd ask if it's been funded already, it'll get rolled out. If they can figure out a way to defund it, I wouldn't be so sure.
Yeah, it's subject to a budget raid. That's
right. My favorite factoid about the overall, ACA bill is $10 billion for IRS agents to enforce the insurance mandate. What Republican in this town is going to vote for that? I think 0. And I think they have a hard time with a lot of this stuff. So if there's some clever appropriator, authorizer, whatever is on this case, and I'll be sure to tell them, they will be thinking twice about this.
I guess in some ways, out on Main Street, I don't care. because the innovation is already occurring. I guess what I'd like to see and what we're trying to promote is a greater degree of innovation outside of the health insurance model, and really looking at health and wellness and what is working there. I think that it continues to be underrepresented. There's more energy out on Main Street about that, but within the Beltway, it's lip service. And so I would like to see a little bit more focus on innovation about how people change their lives and lifestyles in order to be well, as opposed to be the worried well, if you will. And I think that there's a great deal of growing evidence to show that that is an investment worth making. And I'd love to see employers take that on as a much bigger part of their overall employee benefits and engagement strategy to change the lifestyle and the cultures of their workplaces, because that's a great place to start, and then have that build out to their employees' families and really start changing the world that way.
Speak now or forever hold your peace. Well, thank you, and I want to take a moment to thank our panel, Mark Gantz, Tom Miller, Jim Pinkerton. Thank you, gentlemen, for a very good discussion. Fran Marie.
Yes, I would second that. And in fact, I'd like to thank all of our panelists, all of our keynote speakers, all of our sponsors, our Regents Group, Pharma, Eli Lilly, GlaxoSmithKline, Medco, and Excella Government Relations for supporting us over the years and continuing to support us. I want to thank the group that has made this possible, my staff. Thank you very much. Tim, Ron, Jerry, Ty, Katie, Lauren, Patrice, and Tamara. Thank you very, very much. I'm now going to allow Mark Gantz to have the last word.
And the only thing that I would like to say is I'd like to thank and ask that we all give a big round of applause to Fran Marie for a great day. Well, the hour is late, and it's been a very stimulating day. As I said, the Aspen Health Stewardship Project is alive and well. We're going to be taking this forward and continuing to have conversations like this that will help, hopefully, keep the focus on the substance of how we transform healthcare going forward, even as the political bullets fly. So appreciate you all being here, and have a good evening.